Good morning, George. It's another Tuesday morning, and we're back from sunny Miami, and it is 4 inches of snow here in DC.
That's terrible. So today we have another wonderful guest, Dr. Mino Geary. And the topic that we're going to talk about is what happens to a private practice when Medicaid doesn't pay enough to keep the doors open.
Good morning, and welcome to the show. It's a pleasure to have you. How is Chicago? Cold, I hear.
It's -8
Hmm.
without the wind chill, and I'll just put it this way, it's my kid's 3rd snow day. So, yeah, they've been off for, I think, 5 days in a row. Yeah, so
That's
there you
pretty
go.
cold. It's pretty cold out here in New York also. It came to snow yesterday. Dr. Bravo and I were in Fort Lauderdale hanging out at the beach. It was cold over there too, but we came back to reality.
80 degrees cold.
Yeah.
Dr. Minnie, why did you become a pediatrician?
I was always good with kids and enjoyed children, just being with them, playing with them. I took care of family members growing up, but I was also sick. I was ill as a child, as an infant. So I think growing up with that experience also gave me an added layer of interest and commitment to working with children.
And who was, I don't know if I'm saying the name is, but who is Dr. Kundan Giri?
He is retired now. I practiced with him. We practiced together for a good 15 years before he retired. He came to America in the 70s on a special visa. They were inviting Indian physicians over. And he's been practicing for, I think, over 40 years, or he practiced for over 40 years.
So
Oh, he's a staple in the community. A
he
staple in
started
the community. Yeah.
he started his practice in the 80s. And it was a community practice, independent practice?
Yes. So initially, he started his practice in Elmwood Park I can't remember the exact year. I want to say 82, maybe. And he's loved in the community. And when I joined the practice in 2002, we moved a little further west to a suburb called Melrose Park Pediatrics. I'm sorry, Melrose Park. And we opened Melrose Park Pediatrics and built it up over several years. But we brought over a lot of his patients from his Elmwood Park practice and grew from there.
And so was it a two-person practice, you and your dad, for a while?
For a long time, yes, it was 2 of us. I was on call every Saturday or yeah, I think I had no Saturdays off and 24/7 call.
Oh,
So, yeah.
and your dad went through a lot of transitions, right? Because when he started practicing medicine, there was no billing, no electronic medical records. It seemed like every year they dumped something else for the pediatrician to do, and the salary kept getting smaller.
True. Yes, we have I think when we closed, I had to store I don't know, hundreds of charts, and they were this thick because they were handwritten. And we didn't go through the whole scanning process with all of the older charts. There were a lot of the one pagers that I could not read. He had terrible handwriting. And to his credit, he was the first one to suggest adopting the EMR. He was very excited about dictation. He was always trying to stay current and be on the cutting edge of what was happening.
Wow. In your practice, when you moved it, did it became predominantly an access point for children that some sort of challenge, and it meant financial or access to care?
Sure, yeah. Melrose Park is, I believe it's still considered a medically underserved area, MUA. And our peer mix shifted significantly to more Medicaid based practice, which was fine for a while. I think we got paid on maybe a third or a fourth of what private insurance is paid on average. But we were okay. It was more of a fee for service model. And not as many restrictions. Once the what are they called? The MCOs, the managed care organizations took over Medicaid in Illinois, everything changed.
And so so because we're not there, so the neighborhood is mostly brown. The children are lower resources and on Medicaid, probably on Title I schools, and school lunches are provided at school.
Yeah, school lunches. My patient base was mainly children living in immigrant families. So one or both of the caregivers or whoever's in the household, a lot of immigrants, and then children sometimes themselves were immigrants or they were first generation children. There was an added layer, I think, of complexity just because with language barriers and cultural barriers and not really knowing how to navigate the system. One of the things that I think our practice provided for folks was a support system. We, most of the providers or workers in the practice spoke Spanish, and I speak Spanish. We also had a lot of South Asian patients spoke Gujarati, Hindi, but I think that language access was critical to building our patient base. And there's just a different connection you have when people can speak to you in their native tongue.
That
Absolutely.
is
So,
true because our practice has a lot of diversity. We have everybody. I don't speak Spanish, but I have nurses that do, and some of the doctors do speak Spanish. We had a doctor from Pakistan that had a big following that joined us, and patients still speak their native tongue, but with me, they'll speak English. But I have a question for you. So, if you had a lot of Medicaid or Child Health Plus, did you guys take advantage of the meaningful use when the computer time came around? Because that was like the new darling. Everybody wanted.
wow. Yeah, meaningful use is so meaningful. I would spend, yes, I would spend a lot of time working with someone in Springfield to learn how to click all the buttons for meaningful use. When EMRs first came into the picture, we took advantage of that. We adopted eClinical Works. We got government funding to do that. I think that was widely available. We were able to qualify for, I think, the first and second rounds of meaningful use. You have to go through and,
A lot of hoops.
yeah, like lots of parameters and, oh, you didn't follow this algorithm. You should have done it that way. You didn't click on this window. So by the end of practice, I had to hire someone to help us to meet those measures, like a whole extra person, ancillary staff member to help us get the patients logged on. And the other thing is, some of my patients didn't have internet, they didn't have email addresses. This was maybe a decade ago,
Yeah.
right? When we're all starting out, people who don't necessarily are new to the country and don't have income, they have a few extra hurdles. We would help people put together or log into their portals and show them how to navigate the portal. And those were all really, those are difficult. I feel like when I finally, I think the third or fourth round, I didn't qualify. And I wrote my person in Springfield this letter that I hope you realize that you contributed to me closing because it was such a burden to meet these measures. And even when you tried, not being qualified was upsetting.
Now, do you
Yeah.
think it was the technology that created the hurdle, or was it people? Was it culture? Was it the consultant? Because they're supposed to get you qualified.
Right. I don't know. I don't know. They were definitely different processes that we had to follow because we were Medicaid.
Mhm.
And yeah, it's been a while and it wasn't so much the technology, it was just the way our practice was structured, and it has something to do with Medicaid and just being able to get folks engaged in the way that it's a very deep way that the parameters ask you to get people engaged. And that was very difficult for us.
So your practice is what the American Academy of Pediatrics talks all the time about, and what all these politicians talk all about. It's diverse equity and inclusion, and is what they talk so much about. But it's only from here, your teeth out, where you have a legacy practice, a Brown physician committed to the practice, your father, who most likely lived very close to the practice because that was how you did it in the old time. You were going to commute an hour into the office, builds a practice that serves mostly brown immigrant kids who are in pediatric deserts where there's not a lot of providers, clinicians to take care of them. They look like their patient population. They speak the language. They're culturally aware. And then you choke them by regulation and by not paying them enough. And so it irritates me to no end to hear the American Academy of Pediatrics speak about diversity, equity, and inclusion. It cannot happen when you don't support the little practice in the poorest neighborhood, that is the most brown neighborhood, with the immigrant kids and with all the challenges that you just spoke. It is ridiculous to try to get immigrants who may not even read and write in their home country, in their home language, to try to connect to a patient portal in order to pay the physician that's providing the vaccinations for their kids. That is what killed the small community practice. Now, if you really want to get irritated, seems to me that you followed in your dad's footsteps in the same mission of taking care of the most underserved children in Chicago. And you were culturally aware. You grew up in the neighborhood. You had the best of both worlds, perfect English speaking, US training, and you went back to the people that looked like you to serve them. And the lack of payment and overregulation choked you off and killed you mid career.
Wow. To hear it spoken that way, I never wanted to work in a fancy, shiny practice. I always knew that I would work with immigrant patients. Just, I think, reflecting my own immigrant journey, my own healthcare journey as a child. That was never a question for me. And it was really a privilege. Sorry.
Very, very hard, right?
Very
Very
hard.
hard.
Yeah.
You were doing great work for the community. And the AAP, the politicians, they talk so much about how we want to get people like you back in their neighborhood, living their dream. And then we choke them.
I think it was the regulation that choked them
The
because,
lack of payment, George.
well,
Regulation, it was,
there's the first choke. Was the
it was,
regulation.
it was, yeah, regulations were really tough. I know a lot of my peers in practice couldn't even afford the EMRs or adopted much later. Here's what I was going to say. I started before the paradigm turned 180 degrees. I started when I just assumed I would be in this practice forever. There was no question for me that this was the path I'd go down. In residency, I flirted with histology for a while, but then I came back to my roots and wanted to help my father support what he had grown and continue to keep it alive. And we were seeing second generations of so he had the first generation. I would take care of their kids. And by the end, by the time we were closing, the kids were bringing their babies to me. It was really meaningful. And that's what I miss the most is those relationships.
Now, I think that they interviewed your dad. Now, I'm not sure if this was you or your dad, and I'm going to quote what he said. We survived large systems, level changes, strategies for cost containment, establishment of HMOs in the 80s, more recently, the Affordable Care Act and the advent of accountable care organizations. We have watched small practices get bought out by large corporate entities. We've seen private hospitals get bought and sold, transformed, consolidated, and shut down. We've been told again and again that we are, quote, dinosaurs and that we will not survive. It is a challenge to stay afloat in today's complex healthcare environment being pulled in different directions by government regulations, bureaucracy of insurance, and I'm going to add lack of payment because you're getting paid 30 cents on the dollar of the insured patient in, I don't know, what's a fancy neighborhood up there by the airport, just past the airport, past O'Hare. Oh, boys, all the Chicago Bears live
Lake
for us.
Forest, Glencoe, all the places. Yeah, all the places in the Ferris Bueller movie. Yeah, the Medicaid payments were, again, I want to go back to the MCO, the managed care organizations. The state of Illinois basically not sold Medicaid, but
Contract.
transferred, yeah, contracted with thank you, contracted with these organizations. And all of a sudden, it was even harder. You had to make sure that they were on your panel. We had two different systems for ensuring that they were our patients, that they were assigned to us. If we saw newborn babies in the hospital who did not end up coming to our practice and unassigned babies who didn't end up coming and making us their medical home, we wouldn't get paid for those services.
Right.
The MCOs could actually reach back into our accounts and take money that they had paid us for, say, a well visit, because they would say, oh, that person, this is a year and a half later, they would go through their process and they would say, oh, at that time, they did not really qualify for Medicaid. And so we're going to take the money back. I didn't even know such a thing was possible, but that had happened routinely in our practice and other practices I know. The Here I have a great story of spending 6 months calling Blue Cross Blue Shield every day to get paid. They didn't pay our invoice, our charges. It's the right word. For a good 6 months, my office manager would call every day. And then finally one day they said, oh, you haven't been dropping this code. And we were like, did you tell us to drop the code? Oh, yeah, you should have gotten a fax. Or just, there were all these ways of evading reimbursement. I hate that word reimbursement because actually it should be payment. So
Human. Yeah.
e- evading payment.
You know
I
why they do
remember,
it? Why they do it?
so that they can keep the money. 'Cause they can, they,
Yep.
they
I
can't.
remember I have recollections of those things also in our practice. Before we had electronic records and things like that. I had a really militant office manager. She'd go to their website. I discovered these things. There's a website that has PCP acknowledgement. They print out the PCP and it says it's valid. We had thousands of pieces of paper held onto. So when they took it back, we went back to that date and showed it. But you look, your paper says it was okay. We often won with that, but it was a lot of hacks. It was crazy.
It's a lot of work. And
It
I
was.
think we survived as long as we did because we had in-house billing.
Yes.
So my office manager did all the billing.
Mm.
By the end, she was not billing it. She was not a manager anymore, really. She was mostly billing. And I was the manager in addition to practicing. I had to take over HR. I managed all the IT stuff. I worked with the meaningful use folks. That stuff because she was stuck in her room billing.
Yeah.
And
Yes,
yeah,
we've heard from other practices in the Chicago suburbs of how difficult the Blue Cross Blue Shield MCO Medicaid line is. They will acknowledge that they received a claim and then they won't send the payment.
it's not just them. I don't want to target them for this conversation. It's all of them. They take turns. They take turns shafting us. And it's funny because I'm on a WhatsApp group of all the Medicaid providers. I think there's 50 or 60 of us on this group. And it's fairly regular. People saying, is such and such paying you? Oh no, they stopped paying. Oh, you have to do this. Oh, why won't they reimburse for that? Like they're not paying these claims. It's pretty common. And the other thing I wanted to point out was payment in general, tuberculosis, the PPD screening, the needles, that whole process, right? That payment has been the same since I want to say 84 for the procedure. Yes. So you're buying all the supplies to do the PPD, to place it, and they're paying you the same thing that they paid you in 1984. And I think a year or two ago, they finally went up from, I want to say it was $12 or $8, and they went up to 16. And people were rejoicing. And I was like, wow. I think we could do better. I think we deserve better.
The truth of the matter is the TB test, the PPD, that thing is not that expensive. Oh,
Right.
when they went up to make smoke and mirrors because everybody was ordering the TB Gold test, which is probably really expensive.
But it takes time
Right.
to
Yeah, it does. It
even
does.
if it takes 10 minutes of your medical assistance time,
Yes,
that's $5 to the practice before you buy the needle, before you buy the syringe, and they have to come back in 3 days, and then someone's gotta look at it again.
correct.
So it takes and there's gotta be a room where you do it, and somebody has to schedule it. Even if it just takes 20 minutes of your staff at $20, that's $5 to $7 employee cost.
And that's the margins. The margins we're working with are narrow or thin. So every little bit counted. And regarding the quantiferon gold, that's an expensive test.
Correct.
And you have to send when I was first practicing, we drew blood in the practice.
Oh, that,
We did all our CBCs, let all of that. We had phlebotomy services, and I can't remember when that went by the wayside, but there's no way we could have afforded the time, the supplies. It just wasn't worth it. I know a lot of practices can't, afford penicillin injections because they're very expensive and you have to buy them. This was back in the day, you had to buy them in a pack of 6 and then you wouldn't get reimbursed what you paid for the medication. And toward the end, the other procedure that we did often as part of the school physical was the otoacoustic emissions test. And a lot of practices perform that as just a screening for the hearing test that all the physicals ask for. And they stopped paying for that. And the machine itself has to be recalibrated every year. It can be expensive to repair. And they just stopped paying it. So we had to stop doing it.
Yeah, and they never pay for pulse oximetry.
back
Yeah.
in the
Oh,
day,
no.
they used to, but that's
They
when the unit cost like $1,000. Now they're $30.
Again, George, there's time involved.
Yeah, I know. But the
So
pulse
so
ox
somebody has to
is,
do it, and somebody has to interpret it.
yeah,
There's a cost to that. That can't just be in the ether. "Oh, just give it to us for free."
yeah,
When you send out a lab, the 99000 CPT code, nobody pays for it.
yeah.
Somebody has to fill out the form, put it in a bag, put it outside, let Quest or LabCorp know to come pick it up, and 0, Zippo.
Yeah,
They nickel and dime us to the bone.
you are
And so
correct on that.
it's
Yes,
not sustainable. And then particularly the American Academy of Pediatrics, through Healthy Futures or Bright Futures, they never found another thing that can't be done in the exam room. And it's already 100 things. But let's add another 10 for next year. It's impossible.
It was
Impossible.
impossible. Yeah, for sure. And you knew it. And I personally felt like I could never uphold those standards. I felt bad about it
It
because
will,
it was,
you would lose all your patients. They don't want to sit there for 45 minutes and be lectured on and 100 check boxes. They don't. It's my kids as well. Is he growing? What vaccines do I need today? When do I need to come back? That's what most parents want to know. Oh, and by the way, I'm concerned because my cousin in Colombia son got this disease. Is that something my kid's going to get?
Bright
you know,
Futures, when they developed the Bright Futures stuff, it was even the people that invented it could not use it. Okay. It was, if you followed every single step of Bright Futures, each visit would take about an hour plus. It's
Impo-
impossible to do that.
And the parents don't want it.
And they don't want it. They don't want you to lecture. I'm a big proponent of finding things to work around and hack and provide the service. Little things. Dr. Bravo, I'll give him credit to this idea because it was his. He said, "Why do we have to provide all of the Bright Future lecture at every single visit? Make a video and send it to them." So we created the RBK Pediatrics patient channel where every visit you get a link and one of the doctors speaks about what happens at this visit, what vaccines you're going to give. We have an older physician, unfortunately, that's me, and a younger physician that's never seen childhood illnesses. We show them some pictures about vaccines. And I usually will ask them, did you get the link that said the doctors of RBK would like you to watch this video? Most of the people will say yes. Thank you very much. Do you have any questions? Most of you explained everything perfectly. I'll just, for completeness sake, just say a couple of words here and there just to make it look good. But I think that expedited in my life. I cannot get younger generation doctors to follow. They still got to go and do their whole spiel, can talk and talk and talk until they turn
Well,
blue.
I have a question. Did you do it in Spanish?
There's always that. We're going to do it in Spanish. This was a beta test. We did it up until 3 years of age in English because that's what I know. Doctors are very camera shy like you are, and it's hard to get volunteers to do that. I'm trying to get some AI that's going to take our voices and translate it into Spanish. There is some technology out there. I'll put the Spanish link and the English link. Yeah.
Yes, you have a question.
I think that's a great idea. I think patients still want to hear it from you, though.
They do.
And I
Yes,
think
yes, they
that
do.
as you grow in your practice and develop your own technique and comfort level, I think you learn how to connect with patients and figure out what's the most important thing to them in
Right.
the visit.
Okay,
And
let's say that
right.
again.
Yeah, doc, that's a big statement from Dr. Bravo. He says this all the time. Go.
The parent comes in with a set of questions in their mind, and your job is to address those concerns and then give them guidance of the most important things they need to do for their kid. Get the vaccines, do this. The baby's 4 months. It's a good time to start feeding solids, especially if it's a new mom that doesn't have a grandmother around to tell her that. But you're
Right.
absolutely, what is it that they need from you? Because that's why they're coming. They're coming because they want an answer.
So I think we need to just address one other thing that is huge.
Mental health. The doctors are the
Right.
patient.
I'm tired of hearing about physician burnout. Yeah, I don't even, it's like everyone's depressed, right? After a while, what does it mean? But with mental health, I'll just tell you a quick story. I had patient come in. They were early. I was about to go to lunch. The MA's, hey, I think it's just it's ear pain. You gonna go in? And I'm like, all right, let me just take care of them. I don't want them to sit and wait for me while I eat lunch, which is 15 minutes max. And so I go in the room and I get handed this packet, and it's from a psychiatric facility. And it turns out that this girl, the pain in her ears because this man keeps talking to her and saying mean things. So it's the mom doesn't know, she doesn't understand why she was what she has, why she was released with these certain medications. She doesn't like the effects of the medications. The girl's not better. And basically you released a girl with possible schizophrenia or schizoaffective disorder out into the world with, oh, by the way, zero follow-up. So there's who's going to manage those medications? Who's going to see her? Who's going to treat her? Me?
No,
Me? Oh,
beyond your
yeah.
expertise, beyond many levels beyond our expertise.
And even we have the depression screens, the PHQ-9. A lot of physicians have developed a comfort level with using SSRIs and treating anxiety and just doing the basics. But that takes time. It takes time to figure out if a child really needs meds. Why are we throwing medication at children
It's the
like
easy.
water?
It's
It's
the
the
easy.
easy thing because
Yeah.
getting them therapy or thinking about their family dynamics is hard. And you're not going to work that out during a 15-minute visit.
No.
The mental health concerns in my practice were just really difficult on top of everything else.
So I grew up in Colombia, and I didn't grow up in Colombia. I was born in Colombia. And Hispanic culture does not accept mental illness. You talk to my mother about her kid having anxiety, she'll get up and leave. And they don't. And that adds to the burden when you're a pediatrician. You can speak Spanish all you want. You can be culturally similar to them. But when you say your son or your daughter's abdominal pain is not related to anything um, inside his belly, he's anxious. Look at him fidgeting with his hands. He can't stop fidgeting. And they're like, no, there's nothing wrong. It's very difficult. It's a
Yeah.
big, nobody's solved it. What year did Melrose Pediatrics close?
2020, in the
2020.
height of the pandemic.
COVID. Yeah.
Yeah.
COVID killed a lot of practices.
And
We couldn't get masks. We were making our own masks. I
it,
was paying $10 a mask
um,
and we reused them.
Yeah.
and who took over the practice? Did the health systems come out to save it to improve their diversity, equity, and inclusion?
No, it's so interesting. I begged and pleaded for them to partner with me or they wouldn't even take my medical records. They were like, just print out their vaccine records. No, we're not going to store your charts. We don't do that. So all that continuity was lost.
Did
And
the MCOs
the,
come out and say, let's help you start a fairly qualified health center so that we meet our DEI quota?
the MCOs did not do that. I was proactively trying to work on that. We did have interest from a couple. We got strung along by a couple. Looked like was me continuing to work and be the face of the practice. And then the F2HC takes over and decides what EMR to use and all of that. And I lose complete autonomy.
Yeah.
But
Federally qualified centers had CCW more than likely.
did the fairly qualified private equity people come after you to do good?
No one was ever going to offer me money. That was a joke. People laughed at me because when I left those patients that the MCOs would just reassign them. And I don't know where they ended up. There's again, many practices like mine, maybe would have been a farther distance for them to drive and things like that. So they may have ended up there. There were a few practices a few physician referrals that I provided. After I left, two additional practices closed in my area.
Wow.
By the time I left, Gottlieb Hospital had disbanded their pediatric, their nursery, their OB care. Westlake Hospital closed. I was chair of the pediatric department. No one even told me that was happening. Talk about medical desert.
And
Like,
I know I'm being sarcastic, but how many new doctors started practices to replace the 3 practices that were lost, that were maybe hopefully brown, Spanish speaking, female, everything the American Academy of Pediatrics says is necessary to be a good pediatrician? 0.
Zero.
You're very close to the world headquarters of the American Academy of Pediatrics. And did
I work really closely with them
did
even
did
now.
they
Yeah.
did they send out a group of people to help you stay afloat and serve the community in their own backyard? Did they volunteer?
Nope. Go ahead, say it.
Did the $600,000 a year CEO come out on Saturday to help you run patients?
Yes.
Just for community.
I currently serve on the Council for Immigrant Child and Family Health
Yes.
at the American Academy of Pediatrics,
Yes.
and they do a lot.
They do for you. What did they do for that community? What did the state do? What did the politicians do? What did the MCO do? What did the hospitals do? Nothing.
They
This
let her
is
drown. They
we
let her
did
drown.
we did it.
It's
Well, we
really
talk about
interesting. People have said to me,
Fine.
people told me 10 years ago, I was really interested in tech and medicine. I was looking into developing an app to promote healthy lifestyles in children. And I would go to there's a think tank here in Chicago, and I went to a few of their meetings. And I was talking to a few gentlemen, and I explained what I do, and I'm in private practice. And they gave me a thumbs down. And in the middle of the conversation, they were like, it's like, they're like, yeah, QHCs will be doing that. We'll be checking ear infections remotely. And I'm like, I'm sorry. I don't know anyone who would prefer necessarily to send their child to an FQHC if they had options like private insurance.
That part is that from the pediatrician point of view, it's unfair, right? It's just unfair. That just irritates you. But it's a story that we hear across the country. And from a community point of view, who serves its children? Nobody serves the mothers that are delivering. Nobody serves the infants that are delivered. And nobody follows through on the children that are now in the community.
When I was early on in practice, I applied for a catch grant. I can't remember. The AAP offers these catch grants there for community service. And I developed a program called CASA, Consejo Ayuda Salud Alimento. So it's advice, support, health, and nutrition. And we had a whole program where we would get lactation support for the new moms. We would make sure the babies came in at 24 to 48 hours and got weighed. We would check their billies. We did all the things. We tried to put together a support group for young moms. I don't know. It's something I did because I thought it was important. And I was seeing a lot of isolation in my new moms. And I felt like there was something, if there was anything I could do to help establish or reestablish breastfeeding, to encourage it, to give the mom resources that she might not otherwise be able to access. That program was taken over by a hospital, and that hospital closed.
Yeah.
Yes, schools closing. It's a new story, unfortunately.
George's Hospital in Long Island, where they're the last one or two practices going to the nursery, right?
Very interesting. They just told us 2 weeks ago that at the end of January they will be closing the maternity ward and their NICU. And they just changed their CEO. The CEO they had before was fantastic and was pediatric friendly. The OBGYNs, it was like one or two groups, and they wanted them to provide coverage 24 hours a day, but you cannot. And their amount of deliveries have decreased to like 600 a year, which I guess is not enough to sustain a nursery. But again, regulations, they had to keep all the nurses there. And we always wondered, what are these nurses doing when there's no patients? But they really couldn't care less. They just recycled the ward to another ward. The sad part of the whole story was this was the nicest pediatric maternity ward I've ever seen. It was built out for this other large OBGYN group. And then before they even delivered their first baby, they moved on to another big health system. So the ward was struggling. They couldn't get obese to come in. And because they can't get obese to come in, the deliveries come down, and then the NICU service was farmed out to some other university. Those people never wanted to come in to do consults. We're still going to get the babies. They're going to come to us anyway, but it's a sad story. And it was eye-opening for me when I was talking to the CEO and the CFO. Those guys basically were trying to talk down to me, and I'm a little bit of a bully. And I got punched in the nose. We got up and walked out. They don't know they don't have pediatric coverage now in the emergency room. Appendicitis will be shipped out. TNAs will be shipped out. There's a lot of ripple effects by not having a peds ward.
Appendicitis will burst.
Yeah, it's okay.
They'll burst.
They'll
You
go
know,
somewhere else.
this is not a moneymaker.
Yes,
We know that, right? And we didn't go into Peds for the money. But at the end of the day, you should pay me more than $80 for supervising the first 24 to 48 hours of a newborn's life.
correct.
Absolutely.
I think dog walkers make more money an hour than we do when it comes to certain services.
I talk about this all the time. If you factor in New York Medicaid payment for the first year of an infant's care at a pediatrics office, it's about $350. $350 for a year's worth of work. The person that repairs my gas fireplace wants $250 to come out to the house. That's just I'm coming out, it's $250 to come out, plus the time I spend there and the parts I use. It's an unsustainable model. This weekend, we were talking to an anesthesiologist, Kalen. He was in Rhode Island at a maternal infant hospital.
Right.
They did 30 deliveries a day. And as more mothers started to be on Medicaid and more children started to be on Medicaid, the NICU now loses money and their anesthesia group couldn't sustain all the level of care they provided.
The hospital was mandating to provide services that they couldn't sustain
They couldn't make ends meet.
without being on
Yeah.
call 24/7.
You know that thing, if you're not at the table, you're on the menu.
They were on the
Yes.
menu.
Yes.
So when one of the big ACOs moved in, I joined their financial committee. I have no interest in finance, and I'm not particularly gifted in that realm, but I just needed to be in the room to understand better what the stakes were and what the numbers were. And they were getting huge contracts from Medicaid.
Yep.
Huge, massive. And then they would like, oh, this person has, I had a big panel under them. I had 7,800 patients. So they had to be nice to me. And they would give me these bonuses. One year, I promise you that bonus kept my practice afloat. Otherwise, with the advent of the MCOs and the curtailed payments, I would not have been able, I would have closed much earlier. But the CEO came to talk to us one day. And he was like, they wanted us to take over these other hospitals too in the area. Those are losers. So we're not interested. And I was like, oh, that was my hospital where I was chair, and you're calling it a loser. And that's how people think about medical care for underserved children.
Yep. It's a reality.
It's a reality.
I'm so happy, in a sense, the cognitive dissonance of having to work in an environment where I knew these kids all went to the community college down the street. It was like a big deal, just something to celebrate when a kid got to go away for college somewhere nice and have a scholarship. Like that wasn't happening for my patients, a lot of them. That was not the norm
Yeah.
No.
as it is in where I live now.
Yeah.
It's-
Yeah.
You know,
So
I have
Dr.
a question. I have a question that could be a little touching. Your dad, who started the practice, I, I don't know if he's still with us or not with us. How did he feel when he heard that his baby died, basically? His Melrose Place practice closed.
I think it's still hard. It feels like a failure.
Yeah.
And on a very personal level, I feel like I failed my family, but they were also watching me struggle I have young kids, and to be running a practice, seeing patients, being on call, all of those things in an environment where it just felt like I was fighting all the time. I was fighting to get the right medication for the kid. Oh, he's on this. We don't cover that anymore. You have to switch to that. And I was fighting for specialists. I was fighting for mental health services. I was fighting for reimbursement. I was just every minute of the day, I felt it was tough. It was tough.
Medicine is
And
war.
yes, absolutely. Thank you. And I just wanted to mention one other thing. I mentioned the WhatsApp group of pediatricians who are Medicaid providers in our area. We got together once or twice before COVID hit. And ever since then, I don't think people have met in person. But I was astounded walking into that room to see Black and brown doctors. It was immigrants like my father and Black and brown doctors, and a handful of people like me, first generation, who were committed to that work. And there was one white doctor, and he was a Polish immigrant.
Mhm.
Literally all Black and brown immigrants. And to me, that points to a two-tiered system, not only for our children, but for the physicians who come here to practice, that they're relegated to this Medicaid realm, that their credentials are not accepted or valued. And I know it's a whole nother story. It's my story. It's my parents' story. To be fair, no one ever talks about it, about the waves of physicians that they invite when it's convenient for them, when nobody wants to serve in X, Y, and Z neighborhood,
Right.
Let's get some other docs in. So anyway, that's a whole nother layer of complexity and injustice as far as I'm concerned.
You should have all your friends join the Peds United Bliss server because I talk about this a lot and I'm very passionate and angry about it. I don't want to hear one more time die when every foreign medical graduate in the United States is discriminated against. From the moment that you take I took the ECFMG. Now it's just the USMLE. But as a foreign medical graduate, you are not even going to be given an interview at Johns Hopkins, UVA, Cornell, Harvard, Cincinnati, Children's National. You're not.
No
Down there,
way.
it doesn't matter if you're chairman of the Department of Pediatrics at the best children's hospital in India and you're willing to do a 3-year residency. You won't. If you come here as a foreign medical graduate and you do a fellowship in neonatology, you are barred from taking the American Board of Pediatrics and the American Board of Pediatrics neonatology exam to be board certified in neonatology. You're barred
Why are
because
you barred?
you can only take the specialty boards if you can qualify for the pediatrics boards. And you can't qualify for the pediatrics boards unless you do at least 2 years of residency in the United States. So all these great people that come from overseas trained in a specialty, they can never sit for their boards in their specialty. Another just dig in to the community. And then when
And
you talk,
those are the people who are going to take care of the black and brown patients
but they
because they
can't,
speak the language.
but they can't. They have
Right.
to go back to their home countries because they can't sit for the boards unless they're willing to redo their whole Pete's residency and then their subspecialty. And they're not. So they go back to their home country and they do great things there, which is great. We have a shortage of pediatricians. We have a shortage of payment, a shortage of pediatric subspecialists. And to your
You
point
know what?
about
That's okay because now there's mid-level providers.
they don't want to be in primary care because they don't get paid.
They want to go to dermatology.
And
So do I.
and then what you talked about, I talk about this often. It is an elitist conversation to talk about getting children ready for college. 70% of the US children will not finish a 4-year college degree. And very few states, Rhode Island does have a program. There are very few states have a pathway for the kid that is talented in whatever it is. Good car mechanic, they're a good LPN, they're a good carpenter, they're a good plumber. There's so many other things that don't require a 4-year college degree. And there is no apprenticeship or community, what are these called? Community colleges that partner with big employers to get these kids who may not want to do 4 years of a big college to a
Because they can't afford it.
or they just don't like it. Some people just don't like the books. But we all need plumbers. We all need electricians. We all need mechanics, car mechanics, airplane mech we need more LPNs, and why don't we focus on giving the 70% of the population a pathway to a nice middle class living? We don't. We are focused on getting the 30% into the elite colleges. So give all your friends our Peace United, because I talk about this often. Don't tell me about DEI if we're not supporting, and this is, I'm sorry, this is offensive to me, but the woman of color who's a pediatrician in the community of color that has high needs, and she wants to make it work, and we're not supporting.
We should.
So let's stop writing policy papers and talking about it and changing. I can't say maternal infant care now. They're, what do they call them? Birthing people and chest feeders. Let's stop with this nonsense and let's put our brains and our money at making this a reality.
That I read somewhere, I think on LinkedIn, that they're starting to finally see that there's a shortage of PCPs out there, pediatricians, internal medicine. And there is a new pathway for foreign medical graduates to
Yeah.
buy. They can, I don't remember if it was to bypass, if they had a number of years of experience in their home country, they can come here and continue to practice in underserved areas. without the USMLE, or I don't remember if it was with or without residency, but it's without something.
Yeah, Florida is working, and on that, that to me is a little dangerous
Mhm.
and a little unfair. If you're gonna require somebody like your son to go through 4 years of medical school here and then have to do a 2-year residency to be able to get a license, the
Right.
standard should be the same. Maybe we should go back to the times where you finished medical school, did internship, and you were granted a license, and you could be not a family practitioner, but a GP and, just get licensed. No boards, nothing like that. But it should be fair for everybody. It should be fair. And the underserved community should not have a lower standard of care than the fancy toity community. They should all have the
So,
same.
do you know that foreign medical grads, they are required to do rotations, right, as part of their qualification, and they have to pay for those?
Yes, I am
Uh,
signed up for one of them. I know that I have through this, I think it's AMO company, or I was just curious. $3,000 to rotate. You know how much a physician gets out of that 3,000? One. The website takes the other two. It's
right.
crazy. Fortunately, I don't do that. I have my medical students, but I in the summertime, I don't have students, so I was curious and I signed up for it, and I have somebody from Egypt that's supposed to rotate with me in August. $3,000 ticket. It's crazy.
Yeah. You know,
They're paying they're paying,
I
right?
think the
Y
students are paying, and it kills me to take money
Yeah,
from them, but it's the website that's taking the money.
and that's not even a system, like, they're going out and figuring things out. There's no platform where they have qualified mentors and people they can reach out to. There's no system.
Yeah,
It's
people
just
sign up.
it's yeah, ad hoc. "Oh, do you know someone who might be able to" that kind of thing, not and who's signing up? Who has time? I think it's great that you have time to teach people. I didn't really have time to do justice to teaching students. I never felt like I had enough time to sit down with them and go over. I just didn't. I had too many patients. They
yeah.
slowed me down, right?
Well, that's a misnomer, I
Okay.
think. It depends on how the physician uses and works it, because every patient is a board question. Every patient is a discussion. You don't have to sit and read Google what rheumatic fever is to them. They already know that. Talk,
Yeah.
engage, examine, do things, EHR, in the room, talk to the student while explaining to the parent once. It
Yeah.
works, but that's
It works for you. I don't
I know, but that's the way it should be, I think.
I know, I don't think so.
People that followed my system
Like
are successful.
maybe patients don't want a student in the room
I have yet to
to
meet
be.
that patient. They're very happy. These are all stories I hear from doctors that don't wanna do it.
No,
Oh,
George. No.
I don't
I
think.
think you and
Yeah.
Susan Rhoda, you both like that system.
'Cause
I've
we were the
said
same generation, that's why.
I'm your
Walk
same age.
walk and talk. We had a
I
million.
don't believe that's the best way to teach medical students. I think that if you're taking care of patients,
Mhm,
personally me, if I'm taking care of patients, I want to be focused on taking care of patients.
mhm.
If I'm teaching, I want to be focused on teaching. And to me, to do a really great job at teaching medical students, have a conversation. Yeah, you need patience because you can't just, they might as well just go read Google if all I'm going to do is talk about cases that are in front of them.
That's what they do if we don't
But
talk to them.
but you need to show them the patient, but you also need to teach them why is it that you do these things that to us at this point in our career, they don't require any brain power. They're automatic because we've done it so many times.
Right.
But what's your assessment? What's your problem list? Why did
Mhm.
you get the problem list? What do you need to order next to figure out what's wrong with the kid? That all takes time.
Yep.
If it, if you're just gonna walk in there,
Herb, my students they've been checking them. They get the highest grades on the pediatric shelf. I don't know, I may be doing something wrong. The other doctors that do it your way, they don't do that.
you don't know that. Do you have the data? Can you show me the data? Can you
Yes,
show me
we did, and that's the stuff I used to get the doctors to raise that statement, and that's why it worked.
that statement? Where's the data?
Their grades, high
No.
honors.
Well, I
Yeah,
want to
but
know.
you need to compare that to other doctors
Yeah,
and see
they
what the
just pass.
system.
You know
I
what
think
happens? Everybody is just pass fail these days anyway. It's pass fail, honors, high honors. The other doctors all have pass. My students all have high honors. Any
I
difference?
and
I don't know.
I just want to push back on what you said earlier. I think that's not true. I think I have intimate relationships with my parents, and it's off-putting to drag someone in and say, "Hi, this is my student. They're going to watch today. Is that okay?" Are you really giving the parents an option to
Yeah,
say no, not
I've been
You
doing
know,
this for
I don't
20 years
understand.
and it happened
you know,
once.
it's like ice cream. Some people like vanilla, some people like chocolate. So there's not a right or wrong answer,
Yeah,
but not it's not that the system you have and the system Susan Rhoda has is not the only one that works, and
yeah,
not everybody has to follow it. And I personally don't like it, but it
okay.
just doesn't mean that you're doing wrong. You're doing a great job. It's just for me, that's not what I want to do. We drifted off subject here.
Yeah, we always do.
We complained about everything that's wrong with society. I have no idea how we're going to fix it, but it is very distressing to me that all these care deserts are being created not only in urban settings, but even the suburbs like Long Island and rural America.
Yeah.
And no one's thinking about the future because if the moms and the children are not healthy, you don't really have much of a future.
Hopefully this was a way of closure for you, doctor.
Yeah, I don't think I'll ever be able to close that door.
Yeah, it's sad.
Yeah.
Thank you for joining us.
Thank you. Thanks for the conversation.
Yes.
Appreciate it.